Before I start, though, I always remind everyone that suicide is a very personal topic that affects many of us. Many of us are survivors who have lost a friend or a family member or a client to suicide. Some of us are attempt survivors. And so I want you to pay attention to how you feel this morning. If you need to step away from your computer during the presentation, please feel free to take care of yourself. Um, and I want you to do something nice for yourself this weekend because we don't pay enough attention to taking care of the caregivers. And if we don't take care of each other, we burn out, and then we can't do the work that we're doing. And clinicians and healthcare workers feel an obligation to appear healthy and maybe hesitant to ask for help. The biggest risk, of course, for employees is vicarious or secondary trauma when you hear difficult stories that can traumatize the social worker. And we're also vulnerable to compassion fatigue, which can affect our mental health and work performance. Studies show depressed clinicians are more prone to making errors and have a high risk of chronic illness. So you're uniquely positioned to recognize depression in your peers, and you need to seek help when you need it, and take care of yourselves and your coworkers. So on to suicide. It's a global public health crisis. It kills more Americans than car crashes, more people across the world than natural disasters, war, and homicide combined. Kills more soldiers than combat. It's the number one cause of death in teenage girls across the globe. Kills more firefighters than fire and more police officers than crime. And we used to think that suicide impacted six or so individuals that were close to the person who died. But more recent research shows that there are about 135 people who are impacted for every suicide death. And those effects linger across generations because of the silence that often follows. Now, for every negative statistic I'm going to share, hopefully there'll be a positive counterpart when we get to talking about the C-SSRS. The good news, though, or so we thought, was that we saw a decrease in 2019 and 2020 by about 8% in total in suicide for the first time in decades. But in 2021, it went back up 4%, and we lost half of our gains. The largest increase was in males ages 15 to 24. Now, we are losing about 45,000 adults to suicide every year. But for those 45,000 deaths, there are a million and a quarter suicide attempts, and about 12 million people seriously consider suicide every year. So the numbers of people making attempts outnumber those people who die by suicide by about 25 to 1. It's actually about 10 attempts to every one death for the elderly and about 100 attempts to every one death for youth. So the numbers of people thinking about suicide and making attempts far outnumber those who actually die by suicide. And one of our challenges in the field has been in figuring out which of those folks who are having thoughts are most likely to go on to making a lethal attempt. And that's where the Columbia tools you'll see come in handy. Now, why is it important to ask our kids routinely? Because youth tell us that about 6% of your average high school boy and about 11% of your average high school girl will attempt suicide every year. So if you have a classroom of 30 or 40 kids, every year 3 kids in that classroom will attempt suicide. It's usually 2 girls and 1 boy. Girls attempt twice as often as boys do, as you see. But boys die by suicide twice as frequently as girls. And there are a couple reasons for that. The first is that boys tend to choose a method that's much more lethal the first time they try. They tend to choose a firearm or hanging, and girls tend to choose overdosing with medication. And the other thing about boys and men is that there's still a larger stigma for boys and men in seeking help. We see more girls that have been out trying to get help for their depression. And thirdly, depression doesn't always look in boys the same way that it does in girls, or the way that we're traditionally expect depression to look. In teenage boys, depression can look like a conduct disorder, can look like aggression and impulsivity. So they don't always get treated for depression. Now, there's a strong connection between chronic medical illness and suicide. Studies show at least 10% of suicide deaths are connected to a chronic medical condition. Young people who live with a chronic illness are 3 times more likely to attempt suicide than their healthy peers. And there have been 17 chronic medical conditions connected to increased risk for suicide. They include pain disorders, sleep disorders, brain injury, cancer, epilepsy, etc. In cancer, for example, suicide is most common in the first 3 months after diagnosis, with an overall risk that's twice that of the general population. There's also a strong connection between suicide and addiction. We see opiates in 1 out of every 5 suicide deaths and alcohol intoxication in 1 out of every 4. And we see alcohol intoxication in about 30 to 40% of suicide attempts. So if you have an alcohol misuse disorder, you're about 10 times greater risk for suicide than your peers. And if you have an injection drug, if you're an injection drug user, you're about 14 times greater risk. And it turns out that a lot of our opioid overdose deaths that we've been experiencing over the last few years are in fact suicides and not accidental overdoses. They don't always get identified as suicides because coroners and medical examiners don't always have enough information about the motive. But one of our colleagues, Dr. Maria Oquendo, did a deeper dive look at some of these opioid overdose deaths and found that the majority of them were in fact suicides. And it makes a lot of sense when you think about it. What gets people involved in an opioid problem is often a chronic pain issue where they get prescribed opiates by their medical doctor. And we know chronic pain is associated with suicide. Or they might be self-medicating a mental health issue. They might have anxiety or PTSD and using opiates instead of the medication that they might be prescribed. And because of the opiate crisis and our suicide crisis here in our country, we've actually seen our average length of life decrease over the last 10 years compared to every other developed nation in the world where average length of life continues to be increasing. Now, while the greatest numbers of suicides happen in cities because of population density, the highest rates of suicides happen in our rural parts of our country. And there are a couple reasons for that. The first being that in rural America, we tend to have populations that are spread out across a great distance. That can give people poor access to mental health or medical care. Sometimes the closest provider can be 45 minutes away. We're seeing lots of local hospitals closing down. And when it takes an hour to get to a mental health appointment and times are tough and someone's out of work, you don't spend the time or the money to make those trips. The other thing about the rural parts of our country is that if you track all the demographic factors and measure them up against suicide rates, the demographic factor that most closely matches our rates of gun ownership. The more guns in a community, the more suicide deaths we see. And this top map is our map of suicide rates by county in the United States. And the bottom map here is a map of gun shops per 100,000 residents. And you can see that as a proxy for gun ownership. And you can see that those maps look remarkably similar. And this set of data makes that point dramatically. This takes the states with the highest rates of gun ownership and compares them to the states with the lowest rates of gun ownership. Unfortunately, you all are in the grouping of states with the highest rates of gun ownership, where there are guns in half the homes. And in states like the state where I am in New York, we see guns in about 1 out of every 5 homes. And you can see the suicide rate is twice that on average in the states with high rates of gun ownership, 9 per 100,000 compared to 18 per 100,000. And almost all of those excess suicides are in fact firearm suicides. Now, the biggest cause of suicide is a heritable treatable medical illness called depression. 85 to 90% of people who die by suicide have an untreated mental health problem. Most often, that problem is depression. And depression is now the #1 cause of global disability. We've seen about a third of people across the world during COVID reported having stress, anxiety, and or depression. 35% of Americans report feeling anxious or depressed. And our risk is increased during crisis, such as being a refugee or an asylum seeker. Um, you have higher risk. And unfortunately, the effects are compounded for folks who are already vulnerable. Low-income families are hit the hardest by our health disparities and by suicide. With less resources and access to care, rates of suicide and attempts have been rising faster among Black youth than among white youth. In JAMA Pediatrics, it was reported that children living in areas of poverty were 37% more likely to die by suicide. And we know limited access to community support also disproportionately affects our LGBTQ youth, especially if their family is unsupportive. Now, suicide, as I've mentioned, touches everyone, and that makes it a vital part of health and wellness for employees and their families. We need to screen everywhere because depression is the #1 cause of work-related absence and actually costs our workplaces $23 billion a year in lost productivity. And so we've worked with lots of EAPs to make sure that they know how to take care of their employees. And so firefighters, for example, will use the Columbia in 3 different ways. They'll use it to screen civilians in the community. They'll use it to identify members in their department who are in need of assistance, and they'll use it to recognize their own family members who might be at risk of suicide. Now, stigma and misunderstanding, unfortunately, still can be lethal. We see a lot of stigma in help seeking in folks who do very high risk jobs, like being a first responder, or high stress jobs, being a first responder, being a professional athlete, being in the military, being an ER doctor. All of these show increased risk for death by suicide because of the stigma in asking for help. And misunderstandings about suicide can be lethal. When Netflix aired its drama 13 Reasons Why, which is about a teenager who dies by suicide, and she leaves 13 cassette tapes for for peers who she feels mistreated her. We saw a spike in teen suicides after that program was released because of what we call suicide contagion. That's when somebody who's already at risk for suicide because they're struggling with thoughts is exposed to the suicide of another individual. This can be a family member, a peer, or a celebrity. And when that happens, it increases the risk that those already at risk adolescents will make an attempt. Now, we know that antidepressants save lives and not treating depression is what kills people. Autopsy studies of people who died by suicide have been associated with no treatment or non-compliance with treatment. And when the SSRI antidepressants were released in the 1990s, we saw suicide rates decrease until 2000, when the black box warning was put on the side of antidepressant medications that says this may make you more suicidal. Then we saw an uptick in suicides because families and doctors were uneasy about prescribing these antidepressants to adolescents. Incidentally, there's no connection between antidepressant medications and increased risk for suicide. Dr. Posner, who is the first author of the Columbia, was tasked by the FDA to make sense of that data. And what they determined was that there are some additional suicide deaths, but it's not because of the medication. It's because folks who are already struggling with suicidal thoughts, when they get the medications, start to feel a little better. And when they feel a little better and have a little more energy, sometimes that results in making a suicide attempt. Unfortunately, folks who need treatment aren't getting it. We see about 50 to 75% of people who need treatment have no treatment or inadequate treatment. Over 80% of adolescents who die by suicide never received any consistent treatment prior to their death. And with more unemployment, many folks can't afford or access their prescriptions. So a few myths about suicide. The first is that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't stop someone who really wants to die by suicide. Multiple studies have shown that more than 90% of attempt survivors, including those who make highly lethal attempts, don't go on to die by suicide later in life. Most people who are suicidal for a short amount of time. It's one of those symptoms that comes and goes with levels of stress. So if you help somebody through that crisis when they're feeling at their worst, they may never get that suicidal ever again, and that may actually save their life. Asking a depressed person about suicide may put the idea in their heads. The number one reason why people don't ask these questions is that they're afraid that when they ask, it will plant a seed, make it more likely that that person will die by suicide. And that's absolutely not the case. Talking about suicide with someone, talking about their own feelings, does not make it more likely that they'll make a suicide attempt. This is different than the contagion that I just talked about, where someone at risk is exposed to someone else's death. This is simply talking about suicide with someone is more likely to be experienced as relief than as intrusion. And the risk, of course, is not asking these questions when it's appropriate to. Someone making suicidal threats won't really do it. They're just looking for attention. There are folks who talk about suicide frequently or express thoughts about wanting to die. They are at risk for suicide. It's possible to just have this baseline wish to die that never goes away. This is common in folks with borderline personality disorders, for example. But we need to take all threats of suicide seriously, because even if you think they're just crying for help, we need to offer them that help, because the time that we say, oh, that's just Jane, she says that all the time, may be the time that Jane feels like nobody cares, and she may go on to make an attempt. So we need to take it seriously every time we hear it. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. We know that many folks will tell you when you ask, and most are relieved to finally talk about it. And that's because ambivalence is characteristic in 95% of people who are suicidal. The wish to die is fighting up against the human spirit to survive. It's actually hard to overcome that survival instinct and make an attempt in the first place. And it's why we see about 80% give some kind of hints or warnings to friends or family, even if they don't tell a clinician. And those can be very subtle hints or warnings, like themes of death in art or poetry, or writing about suicide in one's journal. Or they can be very blatant. People will come out and say specifically that I'm going to kill myself. Then if you stop someone from killing themselves one way, they'll probably find another. This is the argument for means safety. Means safety is the number one suicide prevention method that we have. And what that is when you put a little bit of extra time in the way of someone who's decided to kill themselves, and when they have the means they're going to use in their hands. And when you can make it take just a little bit more time for them to get that lethal means, it gives a chance for that ambivalence to work. And very often people change their minds. And we have lots of examples about how making it a little bit harder to get lethal means has done just that, reduced suicide rates. In England, for example, in the 1950s, they were using a very toxic coal gas in their cooking stove. They were replacing that at that time with natural gas like we have. And they were able to reduce the suicide rate by carbon monoxide poisoning by a third without seeing much of an increase in other methods. So when someone couldn't do it by asphyxiation with their cooking gas, they didn't go and look for another method. It gave time for the ambivalence to work. Then in England in the 1990s, they were having a problem with Tylenol overdosing. So they passed a law there where they have to sell Tylenol in those blister packages where you punch the pills out one at a time. And they were able to reduce Tylenol overdoses by 44% over the next decade. Right? We buy Tylenol in bottles of 500 at our big box stores. We don't have the same efforts at making it a little harder to get lethal means that some other countries have. And then lots of examples about how making it a little bit harder to get a gun saves lives. New Zealand in 1992 passed a required locked storage law, and they reduced gun suicide by youth by 66%. Incidentally, every day, 10 youth kill themselves with a gun owned by a family member in our country. And in Israel, in the military in 2006, they recognized that they were having a problem with suicides of their soldiers when they were home on leave. So they passed a rule there where when they go home now, they can't take their guns with them. They have to leave their guns on base. And when they're home and they're struggling with their relationships, with their family issues, financial issues, they don't have quick access to their gun. They were able to reduce military suicides there by 40%. And survivors tell us they want us to save them. They want to be helped. Kevin Hines is a survivor who jumped off the Golden Gate Bridge, which is lethal 99% of the time. Kevin tells his story. He was a 19-year-old boy who had a psychotic depression, and voices were telling himself he had to die. But he made an agreement with the voices that if just one person asks me what's wrong, I'm going to tell them and I'll get some help. And he goes to the bridge and he walks across the bridge a couple times. Nobody says anything. He's crying. Finally, somebody comes up to him and says he thinks this is it. I'm going to get some help from her. But instead, she says, will you take my picture? And so he takes her picture 3 or 4 times, gives her back her camera, decides it's hopeless, and he jumped. And what he says now is that he had instant regret. As soon as his hands left that railing, he realized everything in his life he thought was unfixable was fixable, except for what he had just done. And he spends the whole free fall regretting what he had just done. Incidentally, he hits the water and shoots, 100 feet below the surface, and realizes he survived and thinks to himself, this is it. I survived this fall, but I'm going to drown. But finally, he pops up to the surface, and he's floating in the water, and he feels something slimy swimming around his legs. And he says, he thinks to himself, I survived the fall, I didn't drown, and now I'm going to get eaten by a shark. And it wasn't until about a month later he was on a radio program. And someone called in and said, Kevin, I saw you that day. I was standing by you. And I'm so glad that you survived. And I want you to know that that wasn't a shark that was swimming around you. It was a sea lion, and it kept you afloat until the Coast Guard arrived. So he was meant to survive and tell his story in some fashion. And so this is why we're putting the Columbia questions everywhere people acquire lethal means, because we can save a life up until the last minute. So we've trained transit workers in our subways. We've trained pharmacy students. We've worked with gun shop owners to put the questions on bulletin boards in their gun shops. We've done a training with the National Park Service to have rangers have the questions so that they can use them not only with tourists who might be considering jumping from some of our national park high points, but also so that they can use it to save other rangers. And all of this is a synergy between the medical model approach to suicide and the public health model. We used to just take the medical model approach, where we trained physicians and social workers how to identify suicide risk and treat people who were suicidal. But that wasn't making a difference in suicide rates. And so we know now we have to take a more public health approach where we target a whole community, train all gatekeepers, and apply suicide screening broadly across all health services. And we got this idea from the US Marines. They were the first branch of the military that came to us, but they didn't ask us to train their clinicians. They asked us if we would train their financial aid counselors, their chaplains, and their lawyers. Because the number one precipitating event before a Marine suicide is having a legal problem. They get arrested for a DUI and they're attempting suicide because of the impact that could have on their military career. So now in the Marines, every time a Marine meets with a lawyer, the lawyer screens with the Columbia screener and then escorts that Marine to behavioral health if they screen as high risk. So we have to find people where they work, live, learn, and thrive, because they don't necessarily come to us. And so we know that 75% of people who die by suicide die in a home. For ages 5 to 11, it's 95%. And so we have lots of recommendations for screening universally and providing these Columbia questions to as many people as we possibly can. It's why we created these community cards that have the Columbia questions on one side. They tell you which answers are high risk. And then on the front, they address a different population. Ask your spouse, ask your friends, ask your kids, ask your students, ask your athletes, ask your coworkers. And you can print these cards out from our website. You can change the pictures on them if you want. You can add your agency logo. You can add a local crisis phone number if you want. We want these to be as easy to use as possible and to be able to get as many of them out into the communities as we can. And the Air Force has gone the farthest towards this all-in approach to suicide prevention. They not only trained all of their support workers and medical professionals and schools, but they also gave one of these community cards to every airman and to their spouse so that they can look out for their battle buddies and for their loved ones. So let me show you a demonstration video of, that was made by the chaplains in the Air Force to show a peer-to-peer use of the Columbia screener.
Come on.
Airman Powell, hey, how's it going? You look frustrated.
Yeah, I'm just trying to come back from leave and let's work.
How did it go? I knew you were looking forward to that leave with your family. How'd that go?
Yeah, I was. I mean, wish I was still on leave just so I had more time, but
You're pretty frustrated, huh?
It was, yeah, I'm separating soon and just being back home and just made things more difficult and I don't know, it's whatever.
Yeah. You don't really look yourself, you know? Maybe, you mind if I ask you a few questions?
Yeah, that's fine.
Do you wish that you were dead or that you could go to sleep and just not wake up?
I mean, yeah, going to sleep, just, that sounds pretty good.
So have you actually had any thoughts of killing yourself?
Yeah, I have.
Yeah. Well, thanks for being honest with me about it. So have you been thinking about how you might do this?
Oh, I have this gun at home, so,
Yeah.
I mean.
Have you had some intention to act on these thoughts?
I don't know, I clean it and I'm sitting there with it for a while and just, I don't know, things creep into my head and I don't know.
Have you started to work out or worked out the details of how to kill yourself?
I mean, other than sitting there holding it and maybe using it, I don't know, that's just, it would be so easy.
Right. And thanks for being honest with me. Do you intend to carry out this plan?
No, I think about it sometimes, but.
So have you done anything, started to do anything, or prepared to do anything to end your life?
No, not yet.
Well, thanks again for being honest with me. I know you're having a tough time right now. I can tell that. And I'm concerned about you. I think we should go talk with somebody, make sure that you're squared away. How does that sound?
Yeah, I guess so.
Okay.
Okay, in order to prevent suicide, first we have to identify, and that's where the Columbia tools come in handy. The Columbia Suicide Severity Rating Scale was developed in a National Institute of Mental Health research study about 15 years ago, looking at adolescents who had made suicide attempts and what was helpful for them when they were discharged from the ED. It's since been used in thousands of studies. It's available in over 130 languages. English and Spanish are on our website. but if you need another language, just reach out to us and we can send it to you. And it's endorsed, recommended, adopted, or mandated by many national and international agencies like the CDC and the FDA and the Department of Defense. Now, the CDC has adopted the definitions that the Columbia uses, but they don't just have a link to our website and the definitions we use. They also, in their documents, have a list of the words we should stop using. Things like completed suicide, successful suicide. You complete a project and you're successful at your job, and we want to take positive words like that away from an act like suicide. So the recommended language now is to just say someone died by suicide, and to leave out any kind of judgmental or descriptive language when we talk about suicide. So we just say someone died by suicide or ended their life by suicide. Now, the C-SSRS is a semi-structured interview, so questions are provided as helpful tools, but it's not required that you ask all of the questions or in the order that they're written or exactly the way they're written, as long as you collect the proper information in your interview to go back and mark the right spots on the Columbia. Now, you can use multiple sources of information to access the correct answers. Most of the time, the person you're interviewing is going to, give you the answers, but when it's indicated, you can use other sources like family members, caregivers, past medical records. This can be very helpful for children and adolescents whose caregivers may give you better information, more accurate information than the kids give you. It's also very helpful for people who might be psychotic and unable to tell you what's going on, or someone who might be unconscious or intoxicated. You can use the reports from other people. Now, the Columbia tools are just an assessment of suicidal thoughts and suicidal actions. It starts with 5 questions about the severity of the ideation, that increase in risk from 1 to 5, from a wish to die to an active thought of killing oneself with plan and intent. These 5 questions are on both the full assessment Columbia and the screener. Then if you're doing the full assessment version, you have 5 additional questions on the intensity of the ideation. And then we move on to behaviors. And for behaviors, all relevant behaviors are assessed, and all items include definitions for each term and standardized questions to guide the interviewer for the easiest identification. It used to be we just asked about any past suicide attempts. And when that was the only question we asked, we were missing people who practiced how to tie a noose, or who put a noose loosely around their neck and changed their mind, or bought a gun. And we know now that those behaviors have as much or more risk for someone making an attempt in the near future. And we didn't choose to ask about those behaviors. So both the full assessment version and the screener version include all 4 of those behaviors. And then the full assessment version has a final section on any lethality of any actual attempts that were made. So for ideation, this is what the full assessment version looks like, 10 questions. The same first 5 questions are on the screener. Have you wished you were dead or wished you could go to sleep and not wake up? And have you actually had any thoughts of killing yourself? If question 2 is no, you skip 3, 4, and 5. But if question 2 is yes, you'll ask, have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? And have you started to work out or worked out the details of how to kill yourself? And did you intend to carry out this plan? You can't have a method or intent to act or a plan with intent if you've never had a thought before, which is why you can skip them if question 2 is no. Then if you're doing the full assessment version, you have 5 follow-up questions on the intensity of the ideation. And those are questions about the frequency of the thoughts, the duration of the thoughts, how easy or hard is it to control the thoughts, do they have deterrence to acting on the thoughts, and what are the reasons behind the thoughts. And so logically, risk is greater if thoughts are more frequent, if thoughts are longer in duration, if they're a little hard, impossible to control, if they have no deterrence, and if it's to stop pain. And so you can add up the multiple choice answers in this section, and you will get a score of something between 2 and 25. And that can help inform your clinical judgment about risk, but we don't have scientific cutoffs for next steps for this particular section, which is why it's not part of the short screener. But if you work with adolescents, you might want to ask the second question about duration, because Dr. Cheryl King found that it's the most predictive question for adolescents. If a teenager has been thinking about suicide all day long, that's when you would worry most about them. So let's watch somebody asking these 5 additional ideation questions.
Sam was recently admitted to an inpatient unit, and Dr. Green is using the full C-SSRS to conduct an intake suicide assessment. He administers the full C-SSRS for the lifetime timeframe and learns that Sam had one aborted suicide attempt 3 years ago. He went to the edge of a building and was ready to jump, but changed his mind at the last minute. Dr. Green also learns that Sam had an actual attempt 2 months ago, when he tried to hang himself with a rope. Now Dr. Green is going to assess Sam using the recent time frame column. This involves asking questions about Sam's suicidal ideation over the past month and Sam's suicidal behavior over the past 3 months. Let's examine what Dr. Green has found out so far. From the first 2 questions on the C-SSRS, Dr. Green learned that over the last month, Sam has wished he was dead and has had thoughts of killing himself. So he checked yes for questions 1 and 2 and made the determination to proceed with questions 3, 4, and 5. During questions 3 and 4, he learned that Sam recently thought about drowning himself in a pool in his backyard. So he checked yes for question 3. He also learned that Sam intended to act on his plan last week when his family was away, so he checked yes for question 4. When Dr. Green asked the 5th and final question in this section, Sam informed him that he had not started to work out the details of how he would drown himself, so Dr. Green checked no for question 5. Help Dr. Green as he continues to administer the C-SSRS with a focus on assessing the intensity of Sam's suicidal ideation.
Okay, let me just take down some notes here. So, in the past month, it sounds like your ideation was at its worst last week. Is that right?
Yes.
And thinking about last week, how often did you have those thoughts?
I'd say 2, maybe 3 times a day for like half an hour, maybe at a quiet part of the day, and then they'd go away, but later, they'd come back.
And still thinking about last week, when your thoughts were at their worst, did it feel like you could stop thinking about it if you wanted to?
No. I mean, I tried, but no. I mean, I felt like another person. I'd be having the feelings coming home from work and just crying.
Dr. Green gives Sam a score of 5 because he was unable to control his thoughts.
That sounds really tough, Sam. Was there anything stopping you from wanting to die or acting on your thoughts when you felt like this?
Yeah, definitely, yes. Thinking about my family made me want to stop.
Okay.
Dr. Green gives Sam a score of 1 because thoughts of his family definitely stopped him.
Now, what kind of reasons did you have for thinking about wanting to die?
Reasons?
Like, did you want to stop the pain? Did you want to stop the way you were feeling? Did you want attention or revenge or a reaction out of others?
Just stop the way I was feeling.
Completely for that reason.
Yeah, completely.
Good work. Dr. Green has now finished administering the suicidal ideation portion of the C-SSRS for the recent time frame and is ready to sum the numbers to arrive at a score for the intensity of Sam's ideation. Dr. Green sees that Sam's score is 18. Given the scale has a range of 2 to 25, 18 is a fairly high score.
And you can use that score to help inform your clinical judgment about the next steps you might take or the treatments that you might engage in. So we move on to behaviors now. And for behaviors, the 4 specific behaviors are separated out on the full scale. And the first behavior is an actual suicide attempt. And the definition we use and CDC and DOD use is that it's a self-injurious act undertaken with at least some intent to die as a result of the act. There are 3 important parts. The first is that it says self-injurious act. It doesn't say self-injury. There doesn't have to be any physical injury as long as there's potential for injury. So for example, if a gun doesn't go off because it's broken or jams, as soon as they pull that trigger, it becomes a suicide attempt. The second thing is that it says at least some intent to die, where some is the important word. Intent does not have to be 100%, and often people will have mixed motivations when they make suicide attempts. But as long as a little bit of them wants to die when they make their attempt, then it counts as an attempt. Then finally, as a result of the act, meaning that the behavior and the intent to die must be linked. They must be doing that behavior because they want to die. Now, you can infer intent with the Columbia in 2 different ways. The first is that if someone denies they have intent to die, but they thought that what they did could kill them, and they did it anyway, you can infer it was a suicide attempt. Or what we call clinically impressive circumstances. That's where what someone does is so highly lethal that no other intent but suicide could be possible. That's the person who takes 200 pills or who shoots themselves in the face or jumps from the window of a high story. And we're trying to oppose this to non-suicidal self-injury, right? Non-suicidal self-injury is where someone engages in self-harm, and it's purely 100% for reasons other than ending their life. It's usually to affect one of 2 things. It's usually to affect how they feel on the inside, so they're feeling pain and hurt, or they're feeling numb inside. And self-harm behaviors help them to feel better and release adrenaline, which makes them feel present and alive. Or they're trying to affect external circumstances. That's the person who wants sympathy or attention or is homeless and is trying to get hospitalized for the night. Now, the other 3 behaviors we never asked about before are an interrupted attempt. That's when someone starts to take steps to end their life, but someone or something stops them. So they've got a bottle of pills in their hands and someone grabs it from them, whether on the ledge ready to jump and someone pulls them back. And a self-interrupted attempt, which is when a person begins to take steps toward making an attempt, but they stop themselves before they actually do anything self-destructive. So person's planning on driving his car off the road, and before they get to the location, they turn around and come back home. Or someone picks up a gun, thinks about suicide, but then puts the gun back down. Then we have preparatory acts. That's any other behavior beyond saying something with suicidal intent. So something like acquiring means to kill yourself, giving away your valuables, writing a suicide note, looking up ways online to kill yourself. And we think that by asking about all types of ideation and behaviors, maybe we'll find kids like Dylan Klebold, one of the Columbine shooters. He mentioned suicide more than 5 times in his journal, saying things like, I don't fit in here, thinking about suicide gives me hope. And similarly, the Santa Fe shooter wrote in his journals that he wanted to kill people and then kill himself. So if we were looking for all of these preparatory behaviors, maybe we would be able to stop one of these tragedies from happening. Now, the final section on the full scale is lethality. That's what happened in terms of medical damage from any actual attempts that were made. And you'll just ask a few questions about what happened medically, and then pick one of the answers that most closely matches what they tell you. And the final question on potential lethality is there. And that's filled out if there are actual attempts with no medical damage. It's where you can say, even though there was no medical damage, this was a very serious lethal attempt. If they try it again next time, it's probably going to kill them. You're marking what might happen if they tried this again. So let's see someone asking these behavior questions.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? Have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No,
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? That someone or something stopped you before you actually did anything?
a friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No,
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
no, not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
Okay, so she had some significant mental health issues, suicidal behaviors. She had an interrupted attempt, an actual attempt, and 2 preparatory behaviors. So significantly worried about her. Now, for the behavior administration, you're going to select all the behaviors that apply, but only if they're discrete behaviors, part of a separate episode. So if, for example, that the pills she kept under her pillow were the same ones she took in her attempt, you wouldn't count that as 2 separate behaviors. You would just count that as the attempt. Then it's important to ask about behavior, even if all the ideation questions are no, because we have seen some individuals who will say, I never had a thought about suicide before in my life, but I impulsively made the suicide attempt. And then it's important to listen to what the person believes is going to happen and not base your assumptions on what you think about the lethality of their behavior. So this is especially true for very young kids who might do some things that seem strange, but if they say they're doing them because they want to kill themselves, like holding their breath, or putting their head in a pillowcase, it is a suicide attempt if they want to die when they do it. Similarly, for folks who might be psychotic, they might have some strange ways that they come up with to kill themselves. But even if it couldn't kill them, if they are doing it to die, then we call it a suicide attempt. And now all 4 of those behaviors are combined in question number 6 on the screener. And it says, have you ever done anything, started to do anything, or prepared to do anything to end your life? And there are examples of all 4 of the behaviors. So let's see someone doing the screener with an adolescent.
Okay, Amy, you mentioned you've been having a hard time. I'm going to ask you some more questions about that, okay?
Okay.
So, in the last month, have you wished you were dead or wished you could go to sleep and not wake up?
A little bit, I guess.
A little bit. And along the same lines as my last question, have you thought about actually killing yourself?
What do you mean?
Okay, let me rephrase. Have you thought about doing something to end your life?
Oh, doing something. Yes.
Okay. Well, thank you for sharing that with me. That must be very hard to struggle with those thoughts. Tell me, have you thought about how you might do this? Okay. I know it isn't easy, but could you tell me a bit more?
Sometimes I think about just walking onto the road, into the cars.
Okay. And when you've had these thoughts, do you have intentions to act upon them?
You mean actually doing it?
Mm-hmm.
No. No way.
Have you started to work out the details of how you might walk into traffic, Amy?
What do you mean by details?
Have you planned the when or the where you might walk into traffic? This could be the time, the place, anything like that.
Sort of. The street my school is on, it's busy, especially when school lets out. So I guess I've thought a bit about that.
Do you intend to go through with your plan?
No. I've thought about it, but I wouldn't, do it, you know?
Okay. I have some more questions for you.
Okay.
Have you ever done anything, started to do anything, or prepared to do anything to end your life?
Like what? Like try to get a gun or something?
It could be something like that. Or it could be something else. Wrote a suicide note. Started to give away your favorite things to friends. Went to the roof but didn't jump. Anything like that?
Maybe. Once I hid a bunch of pills my mom keeps for headaches, but I wasn't really serious about it.
Did you take any of the pills that you hid? And that was within the past 3 months?
No. It was probably, I think I was 9, and I'm 12 now, so about 3 years ago.
3 years ago. Was that the only time you've ever done something like that?
Yes, that was the first time, and I haven't done anything since.
We've covered a lot of information today, Amy. How are you feeling after answering these questions?
I guess it feels good to tell someone.
I'm glad to hear it. I want you to know you're not alone. A lot of people experience these thoughts, and there are things we can do together to make it easier. Feeling okay?
Yeah.
Dr. K concluded administering the C-SSRS screener, and Amy is set up to get the care she needs to stay safe.
Okay, now the time frames that we asked about, you've probably heard from the videos. We have a version of the full assessment that has two scoring columns, one for lifetime, which for ideation is the time they felt the most suicidal, and one for the recent time frame, which is the past 1 month for ideation and the past 3 months for behaviors. That's when risk is highest. And we believe that monitoring is critical. So we have a version of the screener and the full assessment that says since last contact or since last visit or since last asked. And you can use that every time you see someone, because it's as easy as saying to them, since the last time I saw you, have you had any thoughts about suicide, or have you done anything, started to do anything, or prepared to do anything to end your life? That's questions 2 and 6 asked together. And it takes just a few seconds to ask, and most of the time the answers will be no. So we see no downside. It's all upside to asking every time you see someone. You don't want the time you didn't ask to be the time that you should have asked. Now the science behind it. We have research supported thresholds for imminent risk, which are a yes to questions 4, 5, or 6. So if they've had intent to act on their thoughts within the past month, or they've done one of those 4 behaviors in the past 3 months, they're at highest risk, and they need to have the most extreme next step. Now, that next step might be different on an inpatient unit than it is in the ER or in a school, but if they have a high-risk answer, you don't want to leave them alone until they can be evaluated by a mental health professional, because they might need to be hospitalized. And it's the same on the full scale. A yes to question 4 or 5 in the past 1 month, or a yes to any of the 4 questions in the past 3 months is highest risk. Now, let's see how this officer might use the scale to rule out taking someone to the ER, because that's one of the ways that Columbia is being most useful, is in figuring out who doesn't need the level of care of an ER visit. So we keep those folks out of the ER. So let's see how he does that.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself. So I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to C-SSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that, all right?
Okay.
Good. Have you wished you were dead, or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Okay. So he asked her questions 1 and 2. She said no to question 2. So he skips 3, 4, and 5 and asks her question 6. And she says, yes, I had a behavior, but it was a long time ago, more than 3 months ago. So she's at moderate risk because she had an old behavior. Moderate risk does not require going to the ER. Moderate risk simply requires an outpatient referral. So he could give her the numbers for the local mental health clinics. He could give her the hotline number, 988, and he could ask her if she had someone she could spend the day with so she didn't have to be alone. But she doesn't need to go to the ER. And what we know is that People who go to the ER unnecessarily will, she would sit there for 8 hours or overnight on an ED hold, and then she would be discharged. We know that when that happens, it shuts people down to care. And a study shows that EMS use of the Columbia results in increased rates of voluntary hospitalization. So it improves treatment engagement and reduces the numbers of people who will go to the ER unnecessarily. Now, these 4 behaviors are very important because we only used to ask about past suicide attempts, and it turns out that the vast majority of worrisome behaviors will be these other 3 behaviors. So this one look at 30,000 administrations of the Columbia found that of the worrisome behaviors, only 13% were actual attempts. 87% were these other types of behaviors that we never used to ask about. And so if you're thinking about using a different measure like the PHQ or the ASQ or the P4, you're not going to get all of the benefits of the science behind the Columbia because they don't ask about all 4 behaviors. They don't ask about the intensity. They don't ask about the intent to act on their thoughts. And you're going to miss people who you should be worried about. So as you can imagine, this is having a strong impact on care. Centerstone is the largest provider of outpatient community-based behavioral health in the US. And they are the model agency for the zero suicide model. They use the Columbia for every client at every visit. So if you see your psychiatrist for a medication management visit and then see your case manager, you're going to get asked twice in that day the Columbia screener questions. Then if they score as high risk, they enter their suicide safe pathway of care where their name changes color in their EHR. They get weekly appointments, they get education on a means restriction, and they get a safety plan. We recommend the Stanley Brown safety plan. It's what's considered the highest researched, the most researched and gold standard for safety plans. Then if a client doesn't show for their appointment, the clinician attempts to contact them by phone, and they have phone specialists that do continued outreach to that person. And that never shuts down until they track them down and get them back in. They tell a story to us about a patient that they were working with who didn't show up for their appointment. They're calling and calling and calling, and he finally comes back in and he says to them, the last time you called me, I was on the bridge thinking about jumping. They were able to reduce their suicide rate 65% over the first 20 months and also reduced their hospital recidivism from 40% to 7% when they instituted their zero suicide model. Now, it's just as important to have flexible and innovative delivery as it is to have the right questions. So you can put the Columbia questions on clipboards or on sticky note pads like State of Connecticut does. State of Connecticut has sticky pads for all of their first responders with the Columbia questions on them and a QR code that links to community resources. You can put them on keychains or on your ID badges. There's an app for iPhone and Android. If you search for Columbia Protocol, you'll get the app in the app stores. And it can be put on posters just about anywhere. Now, screening is important because we know that we need to ask these questions the way we monitor someone's vital signs if we're going to find folks who are suffering in silence. We know that over half of people who die by suicide see their primary care doctor in the month before they die. 2 out of 3 adolescent suicide attempters will go to the ER for a non-psychiatric problem. And so we have lots of opportunities where we could be screening. Imagine if every school nurse, physical therapist, or EAP was asking about mental health alongside physical health. If we ask, we'll find them. And then we can screen more at times of higher risk, like when a military person is transitioning from active duty to veteran status, or there are problems at home, or there's a divorce, or some other kind of loss or injury. And screening programs work. Dr. John Mann did a meta-analysis and showed it reduced and lower suicide rates in adults. St. Joseph Healthcare in London showed that with universal screening, they had an increase in comfort levels related to discussing suicide and the destigmatization of the word suicide among both clinicians and patients. A high school screening program did a better job identifying students with mental health issues than allowing the clinical professionals to go out and just find them on their own. And this college screening project was very interesting. They didn't ask they screened their incoming freshman class, but they didn't ask them for the results. They told them, if you're scoring high risk, please come into the counseling center. And what happened was it made a connection between the students and the counseling center so that when they were struggling during the year, more of them came in for counseling than in past years. So it destigmatized the idea of talking about suicide and coming to the counseling center, and increased the help-seeking behaviors. The state of Montana has a grant now to do universal screening in their high schools. They're doing it digitally on laptop computers, and after the screening, if there's a high-risk answer, their guidance counselor is alerted immediately, and they have community partners that have agreed to do same-day at-school assessment for those that are high risk. And they've continuously, in their screening days, found students that were at risk that they didn't know about in the past. And there are still barriers to screening, like stigma, fear, and liability. People afraid because they don't know what to do if they answer yes. So you have to have next steps in place. People who are afraid to ask, again, because they worry that they'll increase the risk, which we know is not true. And we know that the Columbia provides you with liability protection because it's the most evidence-supported measure that we have. Medical malpractice attorneys have said, if you're doing this, which is the gold standard, and taking the appropriate next steps that are indicated, that provides you with as much protection as you can get. You know, people don't get sued for bad outcomes. They get sued for negligence, for malpractice. And all the lawsuits against schools that I know of that have been successful after suicides have been when somebody knew something but didn't say anything. They've not been when somebody used the Columbia and then got them the care that was indicated. And normalizing screening has been reducing stigma and saving lives in the U.S. Army. The U.S. Army did two things. They instituted the Columbia for every medical appointment. It's done on a kiosk in the waiting room, and your provider is alerted immediately before you come into the room if you've had a high-risk answer, and then they can get you to behavioral health. And they moved their behavioral health program into the medical building and out of a separate outpost, so that people don't have to feel ashamed to come in for a mental health appointment. They saved lives, decreased suicide, and reduced inpatient overnights by 41%, which saved them $30 to $40 million of dollars. Now, having a common language is an intervention in and of itself, and asking these questions can literally be medicine because it shows you care. This common language of the Columbia develops connectedness, which saves lives. And even if you're lucky enough to see a professional, it's likely only once a week. So we need to check on our friends, coworkers, and neighbors more consistently. We also help kids by helping ourselves and modeling good help seeking, just like putting on your own oxygen mask first in an airplane. If the cabin loses pressure, you want to take care of yourself and then take care of your kids. And schools offer students the opportunity to build their resilience by developing caring relationships with teachers and school staff. The presence of a trusted, caring adult is often considered one of the most critical protective factors in a young person's life. And I can't overstate the magnitude of connecting and using this common language. You know, Loneliness has devastating health effects that are equal to 15 cigarettes a day, which makes it more lethal than heart disease and obesity. And the Columbia Protocol, therefore, is more than just a method to identify when someone's at risk. It's a framework for normalizing this tough conversation and reducing the stigma around talking about suicide. That promotes connectedness, which is what people who are suffering with depression so desperately need to stay safe. This is how you can reach out to us. You can email us at Dr. Posner's email address, kelly.posner@nyspi.columbia.edu. I'm adam.lesser@nyspi.columbia.edu, but I monitor Kelly's email box, and I will probably answer your questions if you write them to us. You can also go to our website, cssrs.columbia.edu, where you'll be able to download all of the forms that I've talked about, the community cards, or fill out a contact us sheet, and we'd be happy to get back to you in that way.